The glaucoma module will begin right now. Dr. Anuradha and Dr. Vidyadevi and myself will be conducting this module. The first discussion for today under the glaucoma module will be by Dr. Nishrat Sultana Khayyum, who's a professor at Minto Eye Hospital, Bangalore. Her topic will be optic disc evaluation. I give this over to Dr. Anuradha.
COSCON 2021. May I thank the organizing committee members for giving me an opportunity to present this topic. Special thanks to Professor Nagaraju, Professor and Head of Department of Ophthalmology, Minto Eye Hospital, BMCRI. My topic is clinical examination of the optic nerve head. Clinical examination of optic nerve head is very valuable in the diagnosis and follow-up of glaucoma. Stereoscopic optic disc evaluation is the best terminology. It is fundamental for diagnosis and management. What is the requirement? You have to have a good slit lamp and have the illumination and the viewing system coaxial along with lenses that provide stereoscopy and magnification. The lenses used are plus 60D diopter lens, which gives a magnification of 1, and plus 78D, which gives a magnification of 1.1, or plus 90D lens, which gives a magnification of 1.3. Disc size. First note the disc size. Size of the disc varies from individual to individual and from one eye to the other. Define the margin of the disc. The inner edge of the scleral ring is observed to identify limits and size of the optic disc. Size of the disc may be small, average, and large. The small disc is less than or equal to 1.3 millimeter. The average disc size is 1.4 to 2 millimeters. The larger disc may be more than 2 millimeters. Depending on the refractive error or the emetropia a person has, the disc size may vary. This can be assessed by direct ophthalmoscopic aperture by the illuminated slit lamp beam. So in Hague Street slit lamp, you have the apertures which can be focused on the disc margin so that you can assess roughly whether the disc is small, average, or large. Then after the size of the disc, you have to know the cup disc ratio. The cup disc ratio is normally 0.3, but in glaucoma there is an enlargement and deepening of the cup. The neuroretinal rim, that is the area of the optic disc which is occupied by the axons. The thickness, color and contour of NRR should be compared in each of the 4 quadrants. You know about the isn't rule, that is the inferior rim is the thickest, followed by the superior, followed by the nasal and then temporal. Glaucomatous damage may be focal, diffuse or a combination. Normal color of the rim is orange-red. Pallor of the NRR can be noted. Yellow, grey or white is due to atrophic changes, which is suggestive of glaucoma. Retinal and disc hemorrhages. These are very important. Optic disc hemorrhages, Dran's hemorrhages are usually splinter or flame-shaped hemorrhages on the disc surface in the superiotemporal or the inferiotemporal rim. They may be transient, commonly seen in normal tension glaucoma. They last for 2 to 4 months to reappear or disappear. Patients with optic disc hemorrhages are at a high risk of developing glaucoma. Then you see the retinal nerve fiber layer. Examination is best performed using the red free green light through a dilated pupil. Fundus appears darker and deeper red in these areas. Slit defects may be physiological but have to be documented. Wedge-shaped defects extending up to the disc margin are typical of glaucoma. In the later stages of glaucoma, diffuse atrophy of the RNFL is seen, that is the retinal nerve fiber layer defects are seen. Region of the peripapillary atrophy. Evaluation of the peripapillary area atrophy aids in glaucoma assessment. 2 zones of atrophy are present, alpha and beta, surrounding the disc. Inner beta zone represents loss of retinal pigment epithelium and choriocapillaries, leaving intact choroidal vasculature that can be seen as a crescent. Beta zone atrophy is suggestive of glaucoma and increases with the progress of the disease. Peripheral alpha zone is an irregular hypo or hyperpigmented zone associated with chorioretinal thinning. This zone is found in many normal eyes also. So the beta zone atrophy is more important than the alpha zone. Then you have the vascular changes. Bayoneting refers to the sharp 90-degree turn the vessel develops as it dips into an acquired pit of a neuroretinal rim loss, and then emerge out onto the optic disc edge. That is bayoneting. It is the sharp deflection of the vessel at the disc margin. Bearing of circumlinear vessels refers to the unsupported appearance the vessels have when there is no NRR directly in contact with them. Nasalization of the blood vessels occurs as diffuse NRR loss causes the major blood vessels emerging from the nerve to appear more nasal than central. Then narrowing of the blood vessels can also occur as glaucoma progresses. In summary, stereoscopic disc evaluation is the most fundamental and important diagnostic aid. Comparison between two eyes is mandatory in terms of the parameters mentioned above. Documentation of the optic disc, diagrams or sequential optic disc photographs, mono or stereo, that is the photo documentation, helps assess progression, and inter-observer variation is the only limitation. Thank you.
Thank you, Nishat ma'am. PGs should get into a practice of drawing good fundus pictures, also document it photographically. It is very, very important that you make out every time there is change in the course of the vessel or the NRR changes. Thank you so much. So, Dr. Vidya, please introduce the next speaker.
We'll be moving on to the second topic under glaucoma by Dr. Deepak Megur, consultant at Megur Eye Care Center. Sir will be discussing on gonioscopy.
I am Dr. Deepak Megur. I'll be speaking today on Gonioscopy Basics and sharing few tips along the way. I believe that gonioscopy is like a naming ceremony. Every glaucoma suspect has to undergo this ritual so that it can be classified into an open or a closed angle variant. And since we know that the treatment modalities are totally different, it becomes mandatory that every glaucoma suspect subjected to this gonioscopy. The first tip would be to start seeing the angles. Gonioscopy remains one of the most underperformed techniques in clinical ophthalmology, and unless and until we start doing it, it's difficult to appreciate the angle structures. To begin with, patient comfort should be our top priority. Adequate anesthesia by topical drops ensures that the patient comfort is enhanced. An assistant holding the patient helps to position the patient well. All these things make sure that the patient is comfortably put to the slit lamp so the gonioscopy can be performed well. Tip number 2. Don't just gonio the glaucoma suspects. A beginner should see the angles of every patient whom we can manage to see. The first 200 eyes are mandatory to get some idea of the angle structures. The next important thing is it's difficult to appreciate a narrow angle if we don't know how an open angle looks like. So the take-home message is to have a look at the angles of young patients, myopes and pseudophakics to appreciate these wide open angles. Let's look at this picture. This is how a typical open angle looks like. All the structures are seen, while this is an angle where most of the structures are missing and hence it is a closed angle. Moving on to the aspect of the Gonio lens. In the initial learning period, using a lens with the coupling agent such as the single mirror, 2 mirror or the 3 mirror is better as we get better image quality. This helps a beginner to identify the structures pretty well. But it's important to quickly transit to using a 4 mirror lens because it is quicker to perform, it's less messy, and more importantly it is more physiological and indentation gonioscopy is possible, which is extremely critical. However, the image quality is not great though. Number 4. I would recommend all of you to examine the angles under medium or high magnification. We can appreciate subtle signs, but more importantly, the angle structures are beautiful and it's important that we appreciate them in reasonable magnification. One of the common mistakes which I see most beginners do is they would be trying to view the angle in very less magnification. This has to be avoided. How do we identify the angle structures? In a widely open angle, these are the typical structures seen from the ciliary body to the Schwalbe's line. We have an alternating band of hypo and hyperpigmentation. But we need to understand that the angles come with great many variations, primarily because of the variation in the amount of pigmentation. These variations will confuse and mislead most novices. Hence, we require a robust, foolproof landmark which gives us the perfect location of a structure without any bias. So here comes the corneal wedge. When a thin slit beam of light is projected with an angle of 45 degrees onto the angle, a parallelepiped beam of light is seen, and the apex where the two lines meet corresponds to the Schwalbe's line, and this is referred to as a corneal wedge. Now, you identifying the Schwalbe's line using the corneal wedge technique, this is a foolproof way of establishing the position of the Schwalbe's line, and hence accurate assessment of the occludability of the angle is possible. In this picture, let us try to identify the structures. To begin with, at the apex of the parallelepiped light, we have the Schwalbe's line, followed by non-pigmented trabecular meshwork, pigmented trabecular meshwork, scleral spur, and ciliary body. In gonioscopy, the fundamental question which we are all interested in is to know where is the pigmented trabecular meshwork. Now let's look at this angle. This angle is studded with pigments. But by using the corneal wedge technique, the Schwalbe's line is quickly localized, and this pigmented structure posterior to it is going to be the pigmented trabecular meshwork. Now another angle which is devoid of pigment, but the Schwalbe's line is quickly delineated using the corneal wedge technique, and consequently the trabecular meshwork is identified quite easily. Another angle with excessive pigmentation, but we can localize the pigmented trabecular meshwork quite well thanks to the corneal wedge. Now let me ask you in this picture to identify what is this pigmented line. Is it a trabecular meshwork or is it the Schwalbe's line? What is it? When I use the corneal wedge technique, I cannot see the apex where the two light lines meet. It indicates that the Schwalbe's line is also not seen, suggesting a totally closed angle. And this wavy pigmented line is misleading. This pigmented line is anterior to Schwalbe's line and is referred to as a Sampo-Lacey's line. The message here is that corneal wedge helps us to localize the Schwalbe's line accurately and helps us to minimize errors in misreading the angle either as open or as closed, as was in this case. Let us understand the right way to examine the angles for occludability. Number one, the ambient light in the room has to be very low. Gonioscopy is predominantly a darkroom test. The slit beam of the light has to be thin and short so that the light does not impinge on the pupil. Gentle application of the lens over the globe, avoiding excessive pressure. And finally, the patient has to keep looking straight. Now moving on to the last but the most important aspect of gonioscopy, indentation gonioscopy. This is probably the most critical aspect of examining the angles. As I'm indenting the lens, the angle structures are visible, and as the indentation is released, the angle structures disappear. Let us see them once again. I indent the lens, the angle's structures are visible, and again as the indentation is released, the angle is closed. Now let's try to understand how the appearance of the angle is when we view it through different lenses. Now this is an eye with an angle closure. I'm seeing it through a single mirror lens with a coupling agent. The angle is narrow and the pigmented trabecular meshwork is rarely seen as the mirror is rotated in all the four quadrants. Now let us examine the same angle with a 4-mirror lens without using any coupling agent. Now this is the view without indentation, but once I press the lens against the cornea, the angle opens up, shows us what lies beneath. So when I indent, only part of the angle opens up, while the remaining part stays closed because of the broad peripheral antisynechiae. So this is the beauty of indentation gonioscopy. We could identify the part of the angle which was amenable to opening while indentation and the part which was not amenable and was closed by synechiae. With this example, I would like to highlight the fact that gonioscopy is incomplete if indentation is not performed. Indentation gonioscopy provides a complete picture of the angle. It helps in identifying the apposition closure and the synechial closure and will have significant prognostic implications. Hence, it's mandatory that every glaucoma suspect eyes or eyes with narrow angles have to undergo indentation gonioscopy. Well, this was a brief overview of the art of practicing gonioscopy. It's just a primer. I hope that it inspires you to do it more regularly and appreciate the beautiful structures of the angle. Thank you for watching and hope you found this helpful.
Thank you, Deepak sir. That was a wonderful talk. Can we now move on to the next talk, Interpretation of Visual Fields and OCT by Dr. Vidyadevi.
I'd like to thank COSCON for making me part of this PG forum. My allotted topic is Interpretation of Visual Fields and OCT. I'm Dr. Vidyadevi from Optic Hospital. This is a printout of Humphrey Visual Field Analyzer. We have Octopus also, in which a BB's curve will be additional to this. This will be presented in zone 10. In zone 1, we basically have patient's data and test data, which includes the name of the patient, the date of birth, age, pupil diameter, visual acuity, and the refractive error. The age is usually very important because the field has a age-corrected normative data. Otherwise, you get a depressed field. Even the pupil diameter, if it is a myosed or a mid-diatic pupil, we get a depressed field. Refractive error near vision has to be corrected whenever you do this test. Otherwise, you get a depressed field. In test data, we have fixation monitor, wherein a blind spot is usually given a stimulus of about 5% times during the test itself. In fixation target, we have a central fixation, which is usually taken into consideration, or we have a small diamond and a large diamond, depending on the pathology of macula. The color of the stimulus is white here, and the background illumination is around 31.5 apostolips. And the stimulus signs, we usually take Goldman size 3 as a preferred one. 5 can also be taken into consideration when patient has some macular pathology. The testing patterns vary, whether it is screening test, then we take supra thresholds. Normally considered are threshold tests. In zone 2, we have foveal threshold. If the patient foveal threshold, if the patient doesn't focus interior of the bowl, then he'll get a reduced fields. This usually corresponds to your visual acuity. If the patient has good visual acuity, then foveal threshold will be good. Coming to fixation losses, as I already said, blind spot will be usually given stimulus of about 5%, and this is called as Higel-Crackus method. Anything loss of more than 20%, then it will be considered as unreliable. In false positive test, the patient will respond to a non-projected stimulus, and it will be recorded as false positive. More than 20% is acceptable. Anything more than 30% will be recorded as XX in the printout. And in grayscale, it appears as multiple white scotomas. In false negative test, the patient responds, he doesn't respond even to brighter stimulus, and it will be taken as negative response. Again, 20% will be taken as acceptable, more than 33% will be taken as unacceptable. And this usually happens when patient is inattentive, fatigued, or hypnotic, and it will appear as cloverleaf or edge scotomas in grayscale. In zone 3, we have raw data, wherein the exact retinal sensitivity in decibel units of selected points will be calculated by the field analyzer itself. It is basically the numerical values of retinal sensitivity, which will be displayed here, and it will be decibel units. 0 basically indicates absolute scotoma, wherein patient doesn't respond even to highest stimulus of about 10,000 apostolips. And if patient is having 1 apostolips, then it indicates that patient is having very good sensitivity. The grayscale is basically for patient's information, wherein darker shades indicates he is having more problem with the fields, and lesser shades indicate he is having less problem. Coming to total deviation numerical plot, which is in zone 5, it's a raw data wherein it is compared to normal retinal sensitivity, and this in turn will be corrected to your normative data, which is already fed in the machine, and it is age corrected. 0 indicates the retinal sensitivity is either equal to normal patient, which is fed, and anything better than this will not have any sign in front of that. If the retinal sensitivity which is measured is less than normal person, then it will be depicted as minus sign, and this is shown in the printout. With this, we can derive at the global indices like mean deviation index and pattern deviation index. And we can also convert this total deviation numerical plot into total deviation probability plot, which is in zone 6. This basically is a symbolic representation of TDNP plot in p-values, wherein p-value of less than 5% indicates that it is seen only in less than 5% of the patient, and similarly less than 2%, 1%, and 0.5%, wherein a darker symbol says that patient is having more abnormality, while the lower shades say that he is having less abnormality. In zone 7, we get a pattern deviation numerical plot. Here, it's not a true representation of major retinal sensitivity, but this is derived from TDNP plot, wherein the points are raised to 7th best retinal sensitivity point, and we get a PDNP plot. This in turn can be converted to TDPP plot, in the form of p-values. In PDPP plot, it basically what does it do is it unmasks the localized defect from generalized field losses. Coming to zone 9, we have global indices like mean deviation, pattern standard deviation, short-term fluctuations, and CPSD. These last two are seen in your octopus field printout. We have zone 10 glaucoma hemifield test, wherein the 5 zones in the upper field are compared to mirror images in the lower field, and these are got in 5 outputs as outside normal limits, waterline, generalized reduction of sensitivity, abnormally high sensitivity, or within normal limits. When you get a printout, first see whether it is reliable or no. If it is not reliable, repeat it. If it is reliable, decide whether it is localized or generalized. If it is generalized, whether it is uniformly generalized or it is irregularly generalized. Now we'll start with the OCT in glaucoma. We have intersegment OCT and posterior-segment OCT. In intersegment OCT, it basically gives us information about the iris, the angular structures, the ciliary body, and the lens and the iris lens diaphragm. In posterior-segment OCT, we have the info about management of glaucoma by looking into your retinal fiber layers. It also gives the info about your RNFL, which is on the disc, around the disc, and at the macula. So we have two types of OCTs. One is time domain OCT. The prototype is Cirrus. The Fourier domain is your Spectralis. We have different generations of OCTs. This is the OCT printout. We again divide them into zones. Before coming to zones, we need to know something about optic nerve head OCT. This is the printout. This is the OCT of optic nerve head, wherein the green zone, green line, which is seen there, it basically tells us the size of the optic nerve head, which is from one end of Brooks to the other end of Brooks, or it is termination of the choroid. A line which is drawn 140 micrometers above this from either side will give you the cup value. Anything above this is your RNFL, anything below this is your cup. So this printout can be read in 5 zones. Zone 1 basically gives you about the patient's ID. Zone 2 tells you about a T-SNP graph wherein 6 serial scans run over the optic nerve head, and it runs from temporal to inferior side. So it is recorded as T-SNP graph and basically gives us about thickness of retinal nerve fiber layer. In zone 3, this T-SNP graph is corrected to age-corrected normative data, which says that p-value of less than 1% is seen in red zone and p-value of more than 90% is seen in green zone. So when you get a T-SNP graph, that is always put in this double hum patterned RNFL chart, and it is red. Zone 4, we have RNFL thickness in circular pattern, which will come as quadrant forms, and that can again be depicted in clockwise form also. In zone 5, since we scan the optic nerve head, we get numerous values like average RNFL thickness, RNFL symmetry, rim area, disc area, the average CD ratio, vertical CD ratio, as well as the cup value. In zone 6, it's very important whenever we do OCT that area of 3.4 millimeter from center of disc will be charted in your OCT. So the centration of this is very, very important. And zone 7, this basically gives us a percentile color coding, wherein your darker shades like red and green will say that patient is having more of loss, and blue will be showing it as normal values. Another important variant is your ganglion cell complex, which is seen in few printouts, and this basically tells us about the average ganglion cell complex, or it will say about mean ganglion cell complex. And as you know that the ganglion cells are more present at your macula, and this will also help in knowing the progressive analysis of your ganglion cell complex when you want to follow up a patient with glaucoma. Thank you.
So basically what we have to remember is OCT is the pre-perimetric changes. You'll have to look for early changes in early stage of glaucoma. So kindly look for any pre-perimetric changes, because by the time the perimetric changes starts, already the preperimetric changes would have started, and it needs at least 40% of ganglion set death to happen before it could be, shown in your perimetries. So start doing preperimetric glaucoma diagnosis as well. So slowly you can manage and start looking out for Anderson's criteria in perimetry. Okay, thank you. Over to next speaker now.
We will have Dr. Sirish Nelvigi, sir, Director of Nelvigi Eye Hospital, to continue with the next talk, which is IOP measurement and setting the target IOP. Over to you.
Good day to you all. I thank the Karnataka Ophthalmic Society for having invited me for this talk. I also thank Dr. Nagaraju, who is the head of department of Minter RIO, for having put me into this PG refresher course that he's conducting, and which is a huge success. I have been allotted the topic on intraocular pressure and the target pressure. Let me share the presentation that I have. My topic for today is IOP measurement and the target intraocular pressure, how to calculate the target intraocular pressure. There are a huge number of tonometers which are available, right from Goldman Uplanation tonometer to Tonopin Perkins tonometer, and the latest one, which is the Pascal DCT, etc. However, only one tonometer has stood the test of time, which is the gold standard, that is the Goldman Uplanation tonometer. This was developed way back, almost 70 years back, and still it holds good and is still the gold standard. It works by the principle of Invert Fix and has been designed for CCT between 500 to 525. However, there are conditions like keratoconus, high astigmatism, and corneal scarring, where we have to use caution and it may not give a very direct or accurate result. The Invert Fix principle basically says that in a sphere where there is a body of fluid, which is encapsulated in a sphere, when there is a weight which is directly proportional to the force required to upplanate an area of the sphere, this gives the intraocular pressure. So this is the area where the upplanation happens on the eye. This is how it happens exactly. And you use a fluorescein dye to create such a ring or the mire, which we use to estimate the intraocular pressure. As you see, if the mire is something in this shape, we are far apart, where their rings are far apart, that means that the intraocular pressure is low, and then we are underestimating it. And here, if the rings are far higher, that means the IOP needs to be more than what it is there. This is the more accurate depiction of the intraocular pressure, where you have a S-shaped curve with the inner part of each ring, the upper ring and the lower ring, overlapping or just coinciding with each other. When you put too much of pressure on the eye, you might end up with rings which are not complete like this, and a sloppy ring, both the upper one and the lower one. You can see that it's not nicely formed here. And this is how the normal pattern would look like, a neat, nice curved ring where the complete ring is seen well here. Similarly, if too little pressure is applied, you can see a bit of an irregular ring here and irregular contour of the fluorescein over there. And then the rings which are not touching with each other. Again, you need to take care of such situations and then make them come into the normal pattern and fit into the normal pattern. Basically, the method to measure the intraocular pressure is when you make the patient sit on the slit lamp, put a fluorescein dye after putting the topical anesthetic, and then put the maximum illumination in the widest illumination at an angle of 45 degrees of the light of the slit lamp. Once you do that, then you take the applanation tip close to the eye, and then you have to look from one eyepiece and then obtain a ring similar to this. So when you applanate, this is suppose the applanation prism ring or the prism of the applanation tonometer. When it comes in contact with the cornea, it applanates this much area. The corner between the applanated, the prism and the applanated cornea forms the fluorescein dye to remain like that. And this is what we see as these mires over here. So when you have a specific amount of weight which presses on the cornea, that is how the shape of these rings would change and give us the intraocular pressure. Apart from Goldman Uplanation tonometer, we have quite a few other tonometers which are also available, namely the Tonopen, which is helpful in scarred corneas, and it can be used even in a supine position or a standing position. However, there is a lot of overestimation and underestimation with 24 millimeter mercury as the cutoff. It is also one of the preferred methods of measurement in keratoconus, but sometimes the readings can be pretty erratic. Perkins tonometer basically is in close agreement with Goldman Uplanation tonometer and follows the same principle. However, since it is handheld, it can be slightly prone for the errors. Ocular response analyzer is basically a ear-triggered tonometer with bidirectional corneal movement. It's helpful in cases of post-LASIK, and Goldman correlated IOP can be got. And also it gives a host of other readings like costarian hysteresis, resistance factor, and compensated IOP as well. The non-contact tonometer, however, is not so accurate. It usually uses an ear puff to give us the readings, and it is good to be used more as a screening device. Eye care tonometer is especially helpful. This is called as the excursion tonometer. This is especially helpful in pediatric age group where we want to measure the intraocular pressures. The dynamic contour tonometer uses the piezoelectric crystal measuring the pressure and is supposed to be independent of the corneal biomechanics. So this needs a lot of investigation and development is going on this, and then probably in future this may be one of the more reliable tonometers which we may get in future. Coming to the target intraocular pressure, the target IOP is the IOP range at which the clinician judges that progressive disease is unlikely to affect the patient's quality of life. This is a dynamic process, that is adjusting the target IOP or determining the target IOP. It's also that pressure range at which we believe we can minimize the pressure-related component of glaucomatous damage. There is no validated algorithm for the determination of a target intraocular pressure. This does not, however, negate its use in clinical practice. Always record target intraocular pressure in the files, which can be very, very useful. How do you set the target intraocular pressure? The EGS target pressure guidelines go like this. There are four parameters which are important. One is the amount of glaucoma damage, life expectancy, untreated intraocular pressure, and the rate of progression. If the glaucoma damage is very early, then you can afford a higher target IOP. Similarly, if the life expectancy is short, you can still afford a higher target IOP. You don't need to be very tight about it. If the untreated IOP is high, again, you can have a higher target IOP. And then if the rate of progression is slow, you can still have a higher target IOP. For all the other situations, it's the vice versa. Before you set the target IOP, there are some mandatory things that you need to do. First, you need to do a very thorough workup with ocular systemic and family history, ocular examination, gonioscopy, and documentation of baseline optic nerve head appearance. After that, do a structural assessment of RNFL and then a functional assessment using a visual fields. Once you have done these two things, set the baseline intraocular pressure. Especially in low tension glaucomas, you need to take multiple readings, and the highest IOP is taken into consideration as the baseline intraocular pressure. So now we have set the baseline intraocular pressure, baseline visual fields, baseline RNFL, and obtained a proper history. Once you have done that, you set the target IOP arbitrarily based on these parameters. Once you have done that, in general, reduce the IOP by 20% for mild glaucoma, 30% for moderate, and about 40% in advanced glaucomas. With exceptions, of course, higher the risk factors, keep the IOP as low as possible. Remember, there is no sure shot method, and we know that we can go wrong quite a few times, but there is always time when we can rectify it over a period of time. Once you have set the target IOP and achieved it, maintain this target IOP for some time, anything between months to years, and then keep on doing periodic reassessments. When you do the periodic reassessment after a few years, if you see that the visual field progression is not very high, that means that you have hit the target IOP. Just go on maintaining the therapy in this patient, and then you are sure to have maintenance of the visual fields and vision for the patient. If after a few years you are seeing that there is a very slow deterioration which is happening, you need to reset the target IOP by a small point and then change the treatment accordingly to do the same thing. If, however, after a few years, you are seeing that there is a rapid change in the visual fields, that means you need to seriously relook into the target IOP and seriously relook into doing some radical change of the treatment. Using a range for target IOP may be actually a better idea than using a fixed number. Unnecessary treatment this way is actually avoided. Unilateral drug trial always is a good idea if you want to find out whether the drug is working or not while you are trying to achieve the target IOP. So the things that you should do is first assess the risk factors, set a good baseline. Then after that, set a target IOP and hold on to it, and then reassess the progression and find out the risk and reset target IOP if necessary and hold it. Or if you feel that the target IOP has been reached, just hold on to that and process repeats till stability is achieved or lowest possible pressure is reached. How beneficial is it to keep lowering the target IOP? The clinical advantage of lowering is shown here. When you have an intraocular pressure or target IOP of about 70 to 80 millimeter mercury, in this particular trial, 29% of the patients progressed, whereas when the target IOP was lowered by 3 millimeter mercury from this point to 14.5, only 7% of the patients started progressing. So an additional IOP lowering of 2 millimeter of mercury can save almost about 7 sight years for the patient. In summary, use all means and measures to set the right target IOP, reassess at regular intervals and reset target IOP if necessary, and strike a balance between factors which matter to have best quality of life for the patient. Thank you so much for your patient hearing.
Thank you, Sirish sir. That was a very wonderful talk. Since IOP is the only modifiable risk factor in any glaucoma, so it is very imperative that we monitor glaucoma levels properly, IOP levels. So moving on to next speaker, Dr. Vidyadevi.
I would next like to call upon Dr. Chaitra Anup, who is a glaucoma consultant at Keshva Netralaya, Hassan. Ma'am will be discussing about the newer modalities in the management of glaucoma. Over to you, ma'am.
Hi, good afternoon, everyone. I'm Dr. Chaitra Anup, a practicing glaucoma consultant from Hassan. First and foremost, I would like to express my gratitude for the Karnataka Ophthalmic Society for giving me this opportunity. It is a great privilege to talk on this platform. So my topic today is newer modalities in the management of glaucoma. Glaucoma management is evolving. Safer and very less invasive surgical interventions are now in regular use. Lowering the IOP remains the primary focus, as we all know. But just a brief note on glaucoma. It's a progressive optic neuropathy with characteristic visual field defects and structural changes in the optic nerve head. IOP remains always the primary modifiable factor. Glaucoma can be classified as open angle, closed angle, primary and secondary glaucoma. Secondary glaucoma are associated with underlying systemic conditions or local inflammatory causes and any other specific ocular conditions like trauma. There is often a crossover in the management of the glaucoma, but underlying cause always should be targeted. Current treatment of glaucoma is divided into 3 main categories. One is a medical management, next is a laser, and then is a surgery. Definitive diagnosis can be difficult to make given the insidious nature of this disease. A period of observation without any treatment also is quite appropriate because otherwise you would be putting the patient on unnecessary lifetime treatment. There are many medical management new drugs which are in trial and some are in the market as well. Recently we have got these ROCK inhibitors. The rest, as I mentioned here, are all in the trial phase. So Natasudil is the one drug which we have to remember because it is a ROCK inhibitor and it is recently launched into the market. There are 3 main mechanisms of it. It's a ROCK1, ROCK2 inhibitor. Relaxes the trabecular meshwork, increases outflow. It's also a norepinephrine transport blocker, which increases the production as well, decreases the production, and it lowers the epispleral venous pressure as well. Topical ocular dosing in 0.02%. It has to be used once in a day. There is 5 mm reduction in the IOP. Can be used as a monotherapy or also as a combination with PGN. It's a very exciting new investigational drug which we have in the market for lowering IOP. There are very trans-infused side effects like ungingival hyperemia and hemorrhage, self-resolving, no adverse side effects systemically. Lasers are the next modality of treatment. Since there's a very paucity of time, I would be just brushing through the treatment and I would not go into detail. So there's a laser trabeculoplasty, laser peripherectomy, and cyclic photocoagulation. In laser trabeculoplasty, we have 2, as we all know, is the ALT and SLT. A is argon laser, SLT selective laser. Argon laser is used for ALT and NDR laser 532 is used for SLT. SLT has overtaken the argon laser as the preferred technique because less destructive, as can be used as a first line management, can be repeated several times, and always it's well tolerated. Indications for these laser treatment is when you have a maximum tolerant medical therapy and medical treatment is not working, maximum medical management, MMM is what we say. There's poor compliance to the medical treatment. Initial first-line therapy also you can use these lasers. Contraindications are corneal edema, you cannot use. Complete angle closure, glaucoma, lot of PAs you can't use. Secondary glaucoma generally you don't use. Age less than 35 you can't use. There is a newer technique in laser which is called semi-automatic pattern laser trabeculoplasty, which is a PLT. Pascal system is used here, and we use 1000 spots of 100 micrometer in diameter. Minimally invasive glaucoma surgeries are the next group of surgeries which are in talk now. It is a very group of surgical intervention with the main 5 characteristics of high safety profile, because it has got very less side effects, as I have mentioned here. Minimal disruption of the normal anatomy because it's an internal approach, and it is the definition, by definition, of minimally invasive glaucoma surgery should preserve the conjunctiva from surgical dissection. Ab internal approach, as I already mentioned, to clear cornea, and efficacy is a meaningful IOP lowering, though traditional filtering surgeries are always much better done in good hands. Easy use and easily done by physicians as well, and it can be easily incorporated into traditional phacoemulsification, can be used as a combined cataract surgery along with cataract. So MIGS offers IOP lowering with various aspects also. The first approach is by placing a stent which bypasses the juxtafocal infiltration, which is supposed to be the highest place of resistance in the conventional outflow. Another approach is by goniotomy and trabeculotomy, where we excise or surgically incise the tissue. We also dilate Schlemm's canal, and by cannulation by visco and to the collector channels, there's increased drainage of the aqueous. Second group of MIGS is via alternate path. We increase the UV outflow by accessing suprachoroidal space, or by accessing the aqueous humor into subconjunctival space through a small incision approach. The third MIGS is the one where we decrease the aqueous humor production by ablating the ciliary body, endocyclophotocoagulation. So these are only the names which I'll be telling because of lack of time, as I said. Trabecular meshwork bypass by stent placement is this is the first approach of MIGS, where I-stent glaucose, I-stent inject glaucose, and high-dose microstent are used, all to clear cornea only. And then we have excising the tissue as the second method. There is Cahook dual blade, trabectomy is used, or a gonioscopy assisted transluminal trabeculotomy, and a TRAB 360 only is used. Then we have enhancing the aqueous outflow through Schlemm's canal by dilation by putting visco, or by cannulation of the Schlemm's canal. The outflow is increased to Schlemm's canal and the collector channel. So these are the two that we have mentioned here. Enhancing the aqueous outflow to suprachoroidal space is Cypass microstent, and to subconjunctival space is a Zen glaucoma implant. These are the two. This is a deep light gold Solex microstent where the drainage happens to suprachoroidal space. It's a thin structure with a lot of perforations, as you see, which allows the aqueous humor to percolate. Then there's an express shunt, which is also used implanted through the limbus only. This also is another shunt that is used. Transciliary filtration is a newer technique where we use a fugo blade, where a micro opening is made underlying in the sclera and underlying ciliary body, and then the intraocular fluid or the aqueous humor escapes into the eye's lymphatic system. It cuts the tissue just like a laser beam. It's a fugo blade. So that is transciliary filtration. Then we come to the GDDs, or the glaucoma drainage devices, the last topic. And here there's an alternate aqueous pathway is made from the anterior chamber by channeling the aqueous out of the eye through a tube into the subconjunctival space, just like a bleb formation. So there are, it can be used frequently in medication non-responders or any failed trabeculectomy, end-stage glaucomas, which doesn't respond to other medications or other modes of treatment rather. The GDCs are classified into no resistance, those with resistance, and those with variable resistance. GDDs with no resistance is a silicon tube attached to an end plate, acts as surface of bleb formation. Single plate, double plate, Molten implant are non-valve. Beard well implant is non-valve. I'll be just mentioning the names for the postgraduate students. RD is an oral lab aqueous drainage implant, and Express R50. Ahmed glaucoma valve, or the AG valve, AGV, is the most commonly used, easily implantable, and silicon tube connected to silicon sheet valve, head in polypropylene body. The cross section is very important. An inlet cross section of the chamber is wider than the outlet. The Bernoulli's principle, where resultant pressure difference anterior chamber and the bleb helps in the drainage. The valve is designed to open at an IOP of 8. With all devices, long-term IOP control depends upon the surface area of the implant so that the bleb size is predictable. The implant is ideal for patients with disease high IOP but minimal damage like an NQT or a PKP with glaucoma or a glaucoma after RD surgery or a chronic uveitic eye with glaucoma. Ahmed valve, Beovid valve is a pressure sensitive. Ahmed glaucoma valve is a pressure sensitive unidirectional valve that is designed to open when the IOP is 8. So we have chances of hypertensive phase in this, but chances of hypotension is very less because it is valved and there's a control. Indications for these AGVs are neovascular glaucoma, PKP with glaucoma, as I said, RD glaucoma, eye syndromes, traumatic uveitic, open angle that failed trabeculectomy, can't do a repeat trap, epithelial downgrowth, refractory infantile glaucoma, and in contact lenses varus. Contraindications, whether it's an excessive scar tissue in the eye, that is difficult. If the conjunctiva is very thin, pre-existing diseases like SLE or any other collagen vascular diseases, borderline nerve function, you cannot use it. Complications are hypotony is the most, tube obstruction, tube retraction, endophthalmitis, corneal decompensation, graft failure, or other complications. Final considerations in these newer treatment is great strides have been made in the research of glaucoma treatment. Newer strategies will get better results with fewer side effects and less invasiveness. The study for pharmacological approaches gives us great hope, especially in the field of neuroprotection, gene therapy, cell therapy. Great efforts have been made regarding glaucoma treatment research, and results definitely appear encouraging. Hope my talk was informative for all the postgraduate students. I wish everyone very good luck and a very, very bright future. I once again thank the organizers for giving me this beautiful opportunity. Thank you, one and all.
Thanks for the wonderful talk, Dr. Chaitra. Since glaucoma is a blinding disease, we should all remember that right from the beginning of the residency and throughout our careers, kindly document the IOP, start doing gonioscopies, and document our optic nerve findings and treat at the earliest. It can be right from a simple eye drop to the newer modalities, but kindly give lot of importance and then treat it. So good luck to all the postgraduates. Now we'll wrap up this session and go on to next session. Dr. Vidyadevi, over to you. Any questions to be taken?
I thank all the speakers of the glaucoma module for providing such a concise discussion over all the topics in glaucoma.